If you could please copy and paste that and give us feedback, that would be amazing. And for those of you on the phone who can't see anything, but would like slides later on, my email is efield, that's EFIELD, at usetinc.org. If you email me, I will send you presentations back. All right. And Brian, you can start recording.
Okay. I'm going to introduce the staff that's presenting today. We have Christy Duke, who is the senior epidemiologist at USET. And we also have Dr. Jorge Mera from Cherokee Nation. So we'll start with Christy. And let me share the presentation.
Thank you, Brian. I appreciate it. First of all, I wanted to say happy almost Mother's Day to the mothers out there. I know these are strange times. Try to do something nice for yourself. Make your children do something nice for you, and enjoy it the best you can in these strange times that we're going through. I'm going to get started today, and I'm going to just briefly touch on the surveillance data that we have available within the Nashville area. And then I would like to ask you all some questions to consider that we can discuss maybe at the end of the presentation or the end of Dr. Mira's presentation about how USET can best serve you and what we can do moving forward. We received some really good feedback about some things that you might need from us in tangible products, and I wanted to delve a little bit deeper into that today to see what sort of tangible products or services that we can offer you that maybe we have not done, or things that we could strengthen to better meet your needs during this pandemic. Okay, Brian, go ahead. So you can see the numbers have increased with the Abbott testing being in place. It looks like there is more testing going on. We have 26 sites reporting to the Nashville area office. We are doing kind of a joint surveillance project with IHS, looking at the total numbers tested. You can see we are almost at 28,000, and this was as of, that data was reported to Christina yesterday, so that was as of Wednesday close of business. So I would imagine we're well over that now. So, you know, up from almost 800 tests from the previous week, and that's the number in parentheses. The number of positives has increased from 151 to 224 this week, and obviously the numbers of negatives are going to increase as well. So we are seeing more testing out there. We are seeing more positives out there as well. So I'm expecting to see more cases in the coming weeks. So just here are the questions I would like for you to consider and to think about. You don't have to exactly answer these questions at the end, but thinking through these things and answering, thinking about these questions as you're answering how we can better serve you, I greatly appreciate, so we can think through and we can really give you things that are useful to you. What tools can we provide or improve upon? What are your greatest challenges that you're facing professionally during this pandemic? And where do you feel most supported? And this doesn't have to be by USET. It could be locally. It can be from your local health department or on a tribal level. And also, where do you feel least supported? And where do you think that some services could be provided that would help you feel more supported? So just think about those things as I'm going through this, and then we can talk about them at the end. So I just briefly wanted to recap what USET has been providing. As we've developed things, we've sent them out, but I realized that it's been a little piecemeal, obviously, because we want to get them out the door as soon as possible. But I wanted to just take a moment to talk through everything that we've made available and that people are utilizing, and any constructive criticism you have on these or any pointers would really appreciate. So early on, we realized, especially this was prior to the ICD-10 codes being pushed through to RPMS, that there was no great way to track COVID-19 cases, especially for the tribes that were utilizing RPMS. So we developed a standalone tool in a program called REDCap that allowed tribal nations to track cases. Then we had a special request to build onto that that would assist tribes in contact tracing. So we made that available to tribes, and I believe there are now 8 tribes that have taken us up on this offer and are using a REDCap surveillance tool. They're still using it even in addition to the RPMS, now that it has the ICD-10 codes being pushed through. And I believe that they found it to be very useful to be able to conduct active tracking, case follow-up, and for those that are using it for suspected cases, monitoring of suspected cases as well. It's a really great tool. It's easy to use. It's kind of, I call it Survey Monkey on steroids. It's a survey format, but you're not giving a survey. But you can use it either on a computer or a tablet, or you can collect the responses with paper and pencil and then enter them in. So I just wanted to reiterate that that is available for your use. Participation is completely voluntary, and that each tribe will have their own secure account. So it's no data is going to be shared with other tribes. So I just wanted to highlight that and make you aware that it is still available should you choose to use it. Or if you need any other type of surveillance support, if you don't want to use REDCap and you need assistance in trying to figure out how to do that, please contact us and we'll be more than happy to assist with that. In addition to that, one of the things that we discovered early on is that a lot of the advice and public health recommendations out there were not in a format that was intuitive. There was just a whole lot of information. It wasn't just an at a glance sort of thing where you could get a little bit of background and then the most current recommendation. So we decided to take the CDC and WHO recommendations and kind of distill them down into an easy to read format. And we came up with, so far, 5 recommendations for tribal consideration. I'm going to skip over the case definition and then come back to it. Social distancing, just really distilling down what is social distancing and why it's important. When IHS purchased the Abbott ID Now COVID-19 diagnostic testing, we issued one, recommendations for tribal consideration, in collaboration with the IHS area office about what is appropriate use for the Abbott ID Now, the COVID-19 analyzer tool, and when is it useful and when should it not be used and when is it indicated. Contact tracing during an outbreak, we just wrote a recommendation that we are recommending contact tracing and some of the things that tribal nations should have in place should they choose contact tracing. Tori Reeves, who is our resident expert on infection control, wrote a really great one on appropriate use of disinfectants in clinical and other public spaces. We've had a few questions about the use of disinfectants. Should there be any special precautions or any special measures taken during this COVID-19 outbreak? All of these things are on our USET website on our COVID-19 page, and you can refer to them. And I'm going to loop back to the case definition. It occurred to us early on that there wasn't really a a great case definition out there for COVID-19. And because of the problems in particular that our tribes were having with testing around COVID-19, we decided in collaboration with the Nashville area office and Dr. Harry Brown to issue our own case definition regarding COVID-19, and so that tribes could not have to rely just on testing in order to identify potential and probable cases. That is in the process of being updated. The Council of State and Territorial Epidemiologists has since issued a case definition, so we're going to modify ours to be in line with what CSTE is recommending. Although I do have to say we weren't really that far off from what CSTE came up with. So be looking for that. That will be coming out soon. I'm hoping it'll be out by Monday. Go ahead, Brian. We're also issuing weekly surveillance reports, and we issued the first report this week. The next report will come out next Friday, and they'll be issued each Friday thereafter. And it's just a very brief snapshot of what is going on the local level. We take the data that's being reported to the Nashville area office, the testing numbers, and if they're reporting, not all tribes are, and it just gives a daily number of tests, the daily number of negatives and pending tests, and also the cumulative positives. So that tribes can kind of see where are they, how many people per day are they testing, what their volume is. But in addition to that, we are mining state and U.S. Health Department websites and looking at county level data. So we're looking at all of the cases within your purchased and referred care delivery area within your state and then within the U.S. We don't right now have tribe specific data, but for the tribes that are utilizing REDCap, we're going to look at trying to use the REDCap data to apply into there, but we have not done that at this point in time. We were just wanting to get a surveillance report that was useful to you out the door. I will say that if you would like additional metrics or different metrics, we are more than willing to customize your report to better fit your needs. We worked with one tribe and got some input on what they thought was useful and used that as kind of a template for providing information. But, you know, I fully well realize that just because one tribe found it useful, another tribe may wish to look at something different. So please contact us if you would like us to modify that, and we'll be more than happy to do that. As you know as well, we've been shipping out supplies. We've been doing a whole lot of work with sourcing things. That really seems to be the difficulty. As you know, IHS sent out the N95s, but we worked with IHS and identified how many fit test kits might be needed. It looks like there's going to be some more that are needed, and we're trying to source at least some of the solution needed in those kits to help you guys. Surgical masks, gloves, face shields. We just purchased the thermometers. Some of you may have filled out the survey on the thermometers. Those should be coming early next week. Dental packs. Early on, we sent soap and community education materials. We are still sourcing supplies. We are not, other than the thermometers, we're not doing blanket sends to everybody. It's just going to be as requested because we want to tailor what we send to what you need. And of course, as funding permits as well, which is, you know, always the case. But please don't hesitate to call on us should you need anything. And we can't promise, but we'll try to look. We have a whole team of people that are tasked with searching for items for tribal nations. We've also been doing quite a lot of tailored support. We've done a couple of reopening consultations, giving advice on what needs to be done in order to reopen, how to reduce transmission of the disease. Once people reopen, the supply, as I said earlier, supply acquisition. Tori and Amani have done a really great job of offering REDCap support and training people on REDCap, getting them up and running. I know that we've been consulted in terms of data sharing issues, and as tribes are trying to get data from the states, they're not always successful, so we've been able to advise on that. One tribe that is looking at a survey instrument asked us to create the database for them, and the tool, the survey tool, they've developed the tool, but we're going to help them with putting it in an electronic format so it's easy to use. And we've been doing I call them talk throughs, just thinking through things. Okay, when we reopen, how do we do this? Or do we need to see if we can source our own Abbott analyzer? And if so, how would we do this? So just a lot of talk throughs, a lot of advice giving that we've been doing just around all aspects of COVID-19. And as well, Kit Key and Liz and Sissy do a whole lot of advocacy on kind of the policy political side. I will say that's, we've been picking up more and more of that too as this pandemic is progressing. But I just wanted to put that out there to repeat what we do have available to you should you guys need it. And make you aware, pass that on to your staff who may need assistance. And also to talk through, okay, what is it? What else can we do to help you out, or what can we do better? So Brian, go to the next slide, please. So here's what's upcoming. On the left side, the updated case definition. Dr. Brown is working on one for antibody testing recommendations. We've got one in process for community screening. The things that need to be in place if your site is going to consider community screening, reopening considerations. We're working on that as well. One of the things that we are coordinating with, there is something called the National Coordinating Center, which is kind of a hub for all tribal epidemiology centers. They are working with us to develop community and tribal leader educational materials regarding negative results. And how Dr. Mira and Dr. Brown talked extensively last week about how a negative may not be a negative and how that will impact public health. I think that's very important to get that message out there and to get community members to really understand that just because they tested negative, maybe let's not change our behavior right away. To still be deliberate in moving around and not getting back to normal activity too quickly. On the right-hand side are a couple of things that we had just thought of or that people have brought up, and I'll just mention it now to spark thinking. We were thinking about maybe, I know there's contact tracing materials out there, but maybe creating or even adapting a contact tracing manual for tribes to use, and scripts for contact tracers to just read from so they know that the appropriate questions to answer. In addition, with the National Coordinating Center, are there additional community education or tribal leader materials that you feel like you might need in your community? What message do you feel like may not be getting across and that really needs to get across? So just thinking about the potential things that the Epicenter could do for you and what might be helpful and take at least some of the burden off of you guys, please let us know. So with that said, Brian, can you go to the next slide, please? Here are the questions. And as I said, you don't have to exactly answer these, but just consider these questions as I would like to throw it open right now for discussion on what are some of the things that we can do to support you a little better. If anybody has any suggestions or anything, we would absolutely love to hear it, because I think we're starting to plan our next steps in this. Let's see if we have any in the chat.
Everyone is muted, so you will have to unmute yourself if you want to ask a question out loud.
Okay. Well, I'm glad, Carrie. Carrie Janice says she feels like we're getting the support for USET that's appropriate for their needs, and I'm happy for that. But please let us know if there's anything additional that we can do. Where are you guys on contact tracing? We're hearing more and more about this. Is that something that you're considering at your local level? Okay. I know Eastern Band of Cherokee has done like a manual and a script, and I think that they would be willing to share that. So that may be something that we can adapt from Cherokee and share broadly, and that might be helpful to you guys. I just actually got an email from our project officer from IHS for the Epicenter grant about how to estimate the number of contact tracers you're going to need. We just put that on our website. So if that's something you're interested in, let us know. So if nobody has anything else, I'll go ahead and turn it over to Dr. Mira. I know that there is a survey at the end of this. So if you think of anything additional, please let us know, or go ahead and email us at usetepi@usetinc.org. If you can think of anything else, or if you would like a REDCap account for the surveillance tool, we can get you set up on that. All right, I'll turn it over to Dr. Mira then.
Okay, great. Thank you. And Dr. Mara, let me make you a co-host. Okay, Dr. Mara, if you want to give your updates on COVID-19.
Okay. Okay, so good morning, everyone. I will start by presenting to you a viewpoint that came from the Centers for Infectious Disease Research and Policy from the University of Minnesota. And you may have heard this on the news, because although I did present this a few days ago in one of the other echoes yesterday or before yesterday, I saw one of the authors in CNN being interviewed because of this viewpoint. So it has gotten some public attention. So I put this table together from the information that was on the viewpoint that they published, and I'll be happy to send it to Brian and their team so you can read the full paper, which is very interesting paper. So basically what they're saying is, we've had many pandemics in the last 100 years, let's put it that way. And what can we learn from those pandemics and apply it to this one to predict what's going to happen in the future? Or at least to have an idea where the options are. So they're most of the pandemics, as you all know, have been influenza pandemics, and that's what they use as their comparator. And they start by comparing it, what are the similarities and the differences between the H1N1 pandemic and the COVID-19 pandemic. So both are novel pathogens. So everything in green is similar, everything in red is a little bit different, but not really totally different. So these were novel pathogens that were introduced into the community. The population did not have any pre-existing immunity to any of these two viruses. Asymptomatic transmission is possible with both COVID-19 and influenza. They mainly spread through droplets, but there's also an aerosol transmission component that can happen. Both pandemics, well, by the definition of a pandemic, they infect millions of people worldwide. Now, some of the differences which favor the severeness of COVID compared to influenza is the incubation period. Influenza has a shorter incubation period, 1 to 4 days, with an average of 2. And COVID has an incubation period of 2 to 14 days with an average of 5, which that puts a burden on quarantining and contact tracing, et cetera, with COVID compared to influenza. Asymptomatic carrier has been described in both, but it's probably more prevalent in COVID. We don't know the exact number, but it's around 25% based on the published literature. The R naught is greater for COVID, meaning one COVID infected individual, how many other individuals do they infect of the population who does not have immunity? It's 2.7 compared to H1N1, which is about 1.8. And pre-symptomatic shedding of the virus is present in both, but probably more significant in COVID, not only on the percentage of pre-symptomatic shedders, but also on the days that they are shedding. With influenza, you usually start shedding the day before, or at the max 48 hours before you develop symptoms. With COVID, it goes back to 5 or 6 days before you develop symptoms, you start shedding the virus. And maybe, this is not known, but the peak of shedding is probably greater the day before you become symptomatic compared to influenza, which it happens usually the day after you become symptomatic, the peak shedding. So, of the 8 major pandemics that have occurred in the last hundreds of years, there was no clear seasonal pattern on any of them. 2 of them started in winter, 3 of them in spring, 1 in the summer, and 2 in the fall. 7 of these 8 pandemics had an early peak that disappeared over a course of a few months without any significant human intervention. Like there was no vaccines, there was no massive isolation done, etc. Quarantining. And then on 7 of these pandemics, there was a second substantial peak that was larger than the first peak 6 months after the first peak occurred. So these authors give several scenarios of what could happen with the COVID pandemic. So the first scenario is that the first wave of COVID-19, which happened in the spring of 2020, is followed by a series of repetitive smaller waves that you can see here in the graph. This would be the first major peak. That occurred through the summer over a 1 to 2 year period and diminishing around 2021. So this may happen depending on the mitigation measures that are in place and how they are relaxed. Like, for example, we had a big mitigation intervention in the last 2 months, but now in the United States, many of the states are relaxing on those interventions. So it is expected that peaks occur, and if you implement the measures again, the peaks go down to valleys. But this is just, hypothetical. It hasn't occurred before this way. When you look at the most probable scenario, which is what has happened on previous pandemics, the first wave of COVID, which is this one here, will be followed by a larger wave in the winter of 2020. And then it'll drop down to smaller irregular waves and fade out in the face of a year or two. So this is the pattern that occurred on the 1918 influenza pandemic. The same thing occurred on the H2N2 influenza pandemic of 1957. And the same thing occurred in a recent pandemic of H1N1 in 2009, 2010. So, if you consider that this virus, the transmission is very similar to influenza, but worse. I mean, it's more easily transmitted, more asymptomatic shedding, etc. It is not unexpected that the same pattern might happen, what it means is that in October or November, we may be having a really dramatic peak of COVID-19. And the last scenario is that the first wave of COVID-19 in the spring is followed by a slow burn of ongoing transmission, but without a clear wave pattern. And again, this will depend on the geography and on the mitigation measures that are placed in different areas. And this scenario would not require reinstitution of drastic mitigation measures, although you will have people dying and getting sick, across the board in the next 2 or 3 years. So, we don't know what's going to happen, but these are the 3 scenarios that these renowned authors published. So they finally conclude saying, whichever the scenario the pandemic follows, we must be prepared for at least another 18 to 24 months of significant COVID-19 activity, with hotspots popping up periodically in diverse geographic regions, and also depending on the mitigation measures that are applied. As the pandemic wanes, it is likely that COVID-19 will continue to circulate in the human population and will synchronize to a seasonal pattern with diminished severity over time, as we see with other coronaviruses and the past influenza pandemics that have occurred. And I'm not sure if I presented to this audience, and I haven't, I will in our next meeting. We tracked down all the coronaviruses that were detected in Cherokee Nation in the last 3 years. These are not COVID-19 coronaviruses, in patients admitted with pneumonias. And we had clear seasonal patterns for all those coronaviruses. So, you know, it is possible that this will evolve the same way. Okay, following, I'm just going to present a couple of updates that were requested by some of the audience in the other meetings that they wanted more clarification. So one of the questions was if I could expand on what are the neurologic manifestations of hospitalized patients with COVID-19. So there's 3 publications out there. This is the largest one, biggest cohort. This was done in Wuhan, China. It's a multi-center retrospective observational case series of over 214 patients admitted to the hospital with SARS-CoV-2. The main outcome that they measured was 3. They measured if the patients had any central nervous system manifestations, and there in parentheses you can read the different presentations. If they have peripheral nervous system, or if they have muscular manifestations. So this was basically you know, rhabdomyolysis in different degrees. And what they found is that their population, the mean age was 52.7 years, 40% were men, 58.9% did not have severe infections, and only 41%, well, only, not really only, but 41% had severe infections. And overall, there were 36% of the patients, no matter if they had a severe or a mild infection. And I want to clarify that severity was defined by the respiratory symptoms. 36% overall had a neurologic manifestation, of which you could see the cerebral vascular accidents were present in 5.7% of the patients with severe respiratory manifestations versus less than 1% for the other ones. And altered mental status was also the next prevalent with 14%. And skeletal muscle injury was 19%. So their conclusion was that patients with severe infection tended to be older, tended to have more hypertension, but fewer typical symptoms than those that presented with mild infections. So the presentation was more atypical, meaning not so many respiratory manifestations. Patients with severe infection were more likely to develop neurologic manifestations, and most neurologic manifestations occurred early, within 1 to 2 days of admission. But most interestingly, some patients only had neurologic symptoms at presentation. So one of their conclusions is that, you know, if someone presents with altered mental status by itself or a CVA, do not make sure you rule out COVID. Although this is not very frequent, it can happen. And you would not like to admit a patient with those symptoms and not put them on isolation precautions to avoid, you know, in-hospital transmission. So that's what we know of neurologic manifestations of COVID. Another thing that came up was the COVID screening guidelines. So they've been changing on the CDC website pretty drastically. And they changed last week on Monday, and then they changed again this yesterday. Yesterday afternoon. So the CDC guidelines a few days ago came out with these symptoms. So if anybody presents with cough or shortness of breath, they should be screened for COVID. But if they have at least 2 of these other symptoms, they should also be screened for COVID. If they have like fever plus muscle pain or chills plus headache or whatever. That was a little bit confusing for us. So at Cherokee Nation, so what we decided for our screeners, which are usually at the door and not necessarily nurses, so these are people with not that much medical training, we said, let's just give them a list. If they pick up any of these symptoms, which I will put here, any of the symptoms would trigger that patient should be evaluated by a nurse, and then the nurse would, look at the CDC guidelines and sort out if the patient met criteria for screening to do a COVID test. But CDC changed this again on Friday. So basically, we take all this out and we're back to square one, which is these are the screening symptoms that CDC is recommending right now. And if anybody has any of these symptoms, they should be screened for COVID-19. That does not mean that if someone presents, like I mentioned, with a CVA, they should not be screened, or with diarrhea, they should not be screened. But you have to look for, the most probable causes of those symptoms, and if you still have any doubts, then you screen them for COVID. But with these are straightforward. The other thing important to mention here is that the symptoms have to be acute. For example, the initial screener at the door may ask, are you having any muscle pain? And the person may say yes, but that maybe they have fibromyalgia. They always have muscle pain. So that's why we think a nurse needs to be there to tease out the acuity of these symptoms. And if they're not part of a chronic condition, like migraines with someone who has headache, etc. So you don't have to screen people that you don't really are, that don't need to be screened. And of course, we can also screen asymptomatic individuals. That's a different story that we can talk about, but that's a little bit more hazy and with less formal indications. Okay, another question that was asked, since remdesivir, which is the antiviral that Gilead has, got emergency use approval. And so I wanted to, someone asked, okay, where's the data supporting this and what do we have to do if we want to use it? So the study, there's two studies. The first study that was published in JAMA, the one on the left, it's remdesivir in adults with severe COVID-19, a randomized double-blind placebo-controlled multi-center trial. This study was actually targeted to enroll 450 patients. And they had to stop at around 237 because at that place in Wuhan, they were running out of COVID cases because the pandemic was waning away. So they were able to enroll less, which means that the study did not have the statistical power that it should have with the 450 enrollees they were planning. So basically, on this study, they did not prove that remdesivir changed the course of the illness. They did find that patients that had a duration of symptoms of less than 10 days when they were enrolled in the clinical trial, they had a faster time to clinical improvement. 18 days, the ones who got remdesivir, versus 23 days on the ones who got placebo. But that was not statistically significant. The adverse events, which seemed pretty hefty, they were very similar to the placebo group. And that's because the way you report adverse events is basically anything that happens, and it could be even a viral related symptom. But it's noteworthy to mention that 12% of the patients that were on remdesivir had to stop the medication compared to only 5% of the placebo. And I don't have more details on that to see what was the reason there. And then, I'm sorry, the adapted COVID-19 treatment trials, NIH trial, this was done in the US, and this is what led the FDA to approve remdesivir as emergency use. So it's not FDA approved, technically speaking, like any other drug is, but you can use it on an emergency basis until more data is available. And they based their study that those individuals who were receiving remdesivir had a 31% faster time to recovery than those who were receiving placebo. So basically, if you were on remdesivir at 11 days, you would improve compared to 15 days if you were in the placebo group. But although it did suggest a mortality or survival benefit, that was not statistically significant. And the trials, I believe there are several other trials ongoing, and we should hear more in the future. So that's the data of the clinical trials that led to the remdesivir approval. So it's kind of a little bit soft data, but considering the pandemic and there's no other treatment, I think that was the rush to get this approval. But having said that, this is very important that if you decide to treat a patient with remdesivir, It has to be in a suspected or laboratory confirmed COVID-19. So it's very important. They are not requesting a positive PCR. And I think it's wise because we have seen patients that have all the typical signs of COVID and their PCR is negative because there's false negative tests. It has to be on severe disease, meaning patients who have a low oxygen saturation of less than 94% on room air, or they're receiving supplemental oxygen or mechanical ventilation, or are on extracorporeal membrane oxygenator. If the patients are adults, you need a GFR because you cannot use it with GFR less than 30. And if they're neonate, you need a serum creatinine. Everybody should have a liver function test monitored daily because it apparently has an impact on your liver function that needs to be monitored. And one thing that is important to know, because most of us, most of the clinical providers do not regularly participate in clinical trials, but they are requesting an information like if you are submitting this patient to a clinical trial. So any adverse events that occur should be reported within 7 days to the FDA and also to the company, to Gilead. If, as a healthcare provider, you decide to enroll a patient, you need to communicate to the patient or to the patient caregiver the fact sheet information. And also you have to physically give them the fact sheet. And the fact sheet basically says that this is not all the information, I just extracted the main points, that this drug is approved for emergency use, which does not mean it's an FDA-approved drug. Of course, like in any other treatment, the patient does not have to accept the treatment, and that there are potential risks and benefits, and they are basically many of them are unknown, and that you should offer them any other treatment that could be available at that time. Right now, we don't, except for plasma from convalescent donors, we really don't have much else, unless you want to give them hydroxychloroquine, which I would not advise based on the data. And also that you need to document all this in the chart. And but if you admit a patient who's really sick, let's say they're in an event, they're unconscious, and there's no family members around, and they have COVID-19, you can start the treatment until someone can be given the fact sheet and the information. So they give you this little way out for certain circumstances. The other important thing they mentioned is the duration of treatment and the dosing. And basically, if the patient, they use a loading dose on day one, and then it's 200 milligrams on day one and 100 milligrams every day after that. And the duration of treatment is 5 days if the patient is not requiring mechanical ventilation or ECMO, but it could be up to 10 days if they are requiring this. This applies for peds and for adults. And the doses are here on the slide, and they're a little bit different. But there is a change in duration of treatment according to your clinical status. Okay, another question that I had was, what is known about mother-child transmission? And what we know so far, based on several case reports, is that it is unlikely, but it's possible that although some babies have tested positive shortly after birth, it is unknown if they acquired the infection during pregnancy and at birth or after birth, and that the virus has not been detected in breast milk, amniotic fluid, or other maternal samples. So probably not very frequent if it happens at all, but we're really not sure yet. And finally, someone asked about dental settings. What do we do to prevent COVID-19? So this was a surprise to me. I reviewed the CDC guidelines, and dental offices are a high-risk service because during procedures, a lot of aerosols are generated. And as you can, I don't know how your dental offices are, but in our facilities and most of the private places I've been to, they're not closed, they're open. You don't have a door closing the space where the patient's getting the procedure done. And so they're all communicated by air. So you need to train all your staff on this. And right now, you shouldn't be doing anything but emergency procedures. And if you go to the CDC webpage, you'll find all the details, which are not very different from what you would do regarding PPE in another areas, except that you do need to wear an N95 mask if you're doing the procedure on the patient or in the patient room because of the aerosols that could be generated. You also should check for every patient that comes in for symptoms. You should screen them, and if they have any symptoms, they should not undergo the procedure unless it's an emergency procedure, and they should be sent to the hospital for that. So the recommendation are to postpone, all elective procedures, surgeries, and non-urgent dental visits. If the patients are sick, stay at home, and contact patients prior to emergency dental treatment. If a patient has a confirmed or suspected case, if the dental treatment can be deferred, you do it. If it's an emergency, you should take airborne precautions during the procedure. And if the facility does not have negative pressure rooms, if you can, you should try to do this in an OR setting. If the patient is without symptoms of COVID-19, you can provide emergency dental care as long as you implement all the engineering, infection control practices, and work practices in the facility. So the top things are avoid aerosol generating procedures whenever possible, avoid the use of dental hand pieces and their air water syringe, use of ultrasonic scalers is not recommended, and prioritize minimally invasive atraumatic restorative techniques, hand instruments only. Okay, I'll skip this. This is just general stuff that you guys already know. And the protection is the same one for any other PPE, except that N95 are recommended here. I mean, you cannot get by with a surgical mask alone when you're doing the procedure. And the other important thing is that there should be a policy to contact all patients who receive emergency dental care and contact those patients within 48 hours of the care to make sure they're not exhibiting symptoms of COVID-19. And if they are, you need to evaluate the patient and report this. And that is all I have for you today. Thank you.
Okay, great. Thank you, Dr. Mera. We'll go ahead and open it up for questions. If anybody has any questions for Christy during Christy's presentation or Dr. Mera's presentation. Okay. Not hearing any questions, so we can go ahead and don't forget to fill out the SurveyMonkey evaluation for today's clinic. Yeah, does anybody else have anything?
Just a quick note, I added the 4 questions that Christy asked to the SurveyMonkey. So if you think about later on this week, some needs that you have that haven't been met, or go ahead and just click on that SurveyMonkey and you can give us feedback.
Even if it's something that you don't think USET can do, we're getting resources coming into our email inboxes all the time. So it may be something that if it's not something we can do, we can at least pass relevant information along to you.
Okay, well, everybody have a good Friday, and thank you all for presenting.